Hello again, everybody. Thank you for sticking with us. Again, my name is Billy Bennett. My daughter Cecilia is 6, and she has Phelan-McDermid syndrome. I also, coincidentally, also happen to be a pediatric gastroenterologist. I spend most of my time doing clinical research. Before Cecilia was diagnosed, my research mostly focused on informatics and other things that were not really related to people with neurodevelopmental disorders. But after we learned about her disorder, I reached out to some people at the Phelan-McDermid Syndrome Foundation, and I have made a 180-degree turn in my career as far as what I'm interested in and what I'm passionate about. What I hope to come across as is that these are problems that many of us have deep interest in, but not just from a professional level. I think many of the people involved today have lots of professional experience, but it really is a testament to the fact that these disorders affect huge numbers of people. Almost everyone has at least a distant relative, if not a sibling or a child that has a neurodevelopmental disorder. So that these are things that are hugely impactful and affect families. So I'm just going to share my screen, and I want to talk to you guys about a couple things. So first, I want to contextualize what we've talked about so far. I think I was very impressed by the family panel that you just heard. I think it really put in perspective the gravity of these problems and the need for us to come up with better solutions, better tools, better ways of talking to families. Almost everyone had an experience where a doctor didn't listen to them, or a doctor wanted to treat their child like any other child. And I want to make the argument that that taking good care of children and adults with special needs requires many different tools. It requires partnerships with patient advocacy groups, partnerships with industry, partnerships with clinicians and clinical researchers. And one of the purposes of this conference is to bring us together. We're all stakeholders in this enterprise. And if we can come up with ways to approach this problem as a unit, rather than a bunch of individual people trying to solve problems in individual silos, then we're much more likely to be successful. So I have no conflicts of interest relevant to this topic. So I want to start with kind of my version of the family panel, and because my experience has colored what kind of research I do, what kind of doctor I am, how I talk to members of our community about this. So this is Cecilia when she was about 6 months old, and you can see that she's got a little bit of red hair forming, which is, as you'll see in a moment, a very important feature to me. And this is about whenever we first started noticing that she had some developmental delays. She had a hard time sitting up on her own. She seemed to have low muscle tone. She was feeding well and seemed healthy otherwise. So her pediatrician was, just reassuring us. And I think that's an experience that many people have had in this community. And then getting close to about a year is when things really became more apparent. This is her twin brother, Silas, who is neurotypical. And we started noticing that she was falling further and further behind, that she would meet milestones a few weeks later and then a couple months later. And so at that point, we talked to her pediatrician about it, and she got an MRI and she got a chromosomal microarray. And it's one of those moments that, like, I think, every parent on this conference remembers when they found out that their kid had a a incurable genetic disorder that would have an enormous impact on their lives and our lives and their siblings' lives. And I remember at the time thinking that it was the worst thing that had ever happened. It was just an awful feeling that didn't go away. But I have to tell you that that's probably been the best thing that's ever happened to me. It has drastically altered how I see my job, what kind of research I do, how I interact with my neurotypical children, how I view the world. Is that I have a daughter that is always going to be my daughter. She's never going to leave. I'm going to have to be her advocate for her whole life, and then probably beyond that. And I don't know that I think I got that as a clinician or a researcher before I experienced it personally. And that's one thing that I hope that this conference communicates to those that work clinically and in research, that these problems, and I know I'm biased because I'm a gastroenterologist, but especially problems that are related to the GI tract seem to connect to everything else in the body. And we have to do a lot more to help these problems. And as an example, Cecilia has something called cyclic vomiting syndrome. And there's some specific criteria. These are called the Rome criteria that we use to diagnose most GI functional problems. And functional problems are disorders that don't have a blood test or a biopsy or an X-ray that tells you that's what it is. It's just something's not working right with the GI tract. And almost all of them are disorders that have to do with the way the nerves work. The problem is that these criteria are built on neurotypical children, or really they're built on a population of children, the vast majority of whom do not have other disorders. In fact, one of the criteria for any of these diagnoses is that the symptoms cannot be attributed to another condition. And this makes it quite difficult because it's pretty easy for a doctor to say, oh, your child has this neurodevelopmental disorder, so that's why she's vomiting all the time. Even though she may benefit from an approach and diagnosis and treatment that is how you would deal with cyclic vomiting syndrome in any other child. So this is one thing that I think should be a takeaway from this conference, is that we need better ways to diagnose things that take into account the unique difficulties that occur in people with neurodevelopmental disorders and autism. Thankfully, Cecilia doesn't have symptoms too much anymore, and it's usually just if she's on a trampoline or on a car ride, then she tends to to go into a cyclic vomiting episode. So I want to sort of contextualize this as at the big picture level, that the population that we want to serve, that we're looking at today, are those with neurodevelopmental disorders in general. And this includes people with non-syndromic autism. This includes people with specific genetic disorders. This includes people that have developmental delay and we don't know why. And there are two groups that we can learn a whole lot from to help people in this group. One is neurotypical individuals. So we have all of these diagnoses in the Rome 4 criteria that have specific criteria where we have decades of research in how to treat. But we can't, but it's so much harder to diagnose people with NDDs with these disorders because they have so much more complexity. Doctors are often less willing to give them to give a child with autism a diagnosis of irritable bowel syndrome, for instance. But in my experience clinically, there's probably more kids with ASD who have IBS than in the general population. Yet people don't often take that approach, and we need to change that. And on the other side of things, if you didn't learn anything else from the family panel, you should have learned that there is probably more in common among all these different disorders than there is different. Many people with NDDs have hypotonia, they have intellectual impairment, and they have a lot of GI problems that would benefit from a similar approach. And so things that we learn in one disorder, we ought to be able to generalize and use effectively in other disorders, but it's going to take some effort. And my hope is that, and that's why the last segment of this conference, we decided to do working groups, is that we hope that this thought process and this coming together is a perpetual thing. We have a website and everything. So if you have a website, that means that you want to stick around. So the first thing I wanted to talk to you guys about were the results of the Candid GI survey. So we had a survey that went out a few months ago online. And we asked the families of those with neurodevelopmental disorders to participate. And this was in partnership with a bunch of different patient advocacy groups who then disseminated the survey link to their membership. And getting 717 busy special needs parents to participate in this is, I was very happy with this. This is an achievement. I would have been happy with 100, but the fact that we got over 700 was fantastic. And so this used a platform called REDCap, and REDCap allows you to collect data anonymously and then store it in a database. And we got demographics, we got which GI symptoms people had, and then the big part of it was we administered 2 different scales that look at GI symptoms. One of them is called PROMIS, which was created as a part of an NIH-funded effort, and the other is the PEDS-QL, which is probably the most commonly used quality of life measurement in children and young adults. And our main goal was just to look at the impact that GI problems in general and specific symptoms have on the quality of life for individuals and families. But we have to admit that a sneakier goal was to show just how inadequate these measures are, simply because they were developed without taking into account the complexity of children and adults with neurodevelopmental disorders. And I do admit that with most research that we do, there's always a main goal, but then and we call that our primary outcome. And there's always a sneaky goal, like something that we know will be harder to convince people of, but we still want to know about it too. And that's called a secondary outcome. And so the qualitative part of this study was our secondary outcome. And so we also solicited feedback from these communities, both from leadership of the different patient advocacy groups, but as well as the families that completed the survey, is tell us what you thought about it. And this was absolutely what we anticipated. And some of these quotes are just fantastic. And we anonymized everything, but if you've joined and you recognize your quote, I haven't changed anything, although I have cut some stuff out. So this is a huge issue right here, is just that it was very difficult to complete these surveys because so many questions are things that need to be reported with some type of communication, either verbal or otherwise. And as this person said, our child cannot communicate the majority of her issues with us. We can only see the results. We can only see objective findings. This next person said that they're very happy. They said it's great to have neurodevelopmental disorders work together to understand quality of life, but it was hard to answer the questions since most of our affected individuals are nonverbal. So we don't really know the extent to which pain or discomfort or other GI symptoms are affecting them. And for the non-clinicians in the audience, this is sort of a pedantic thing, but there's a difference between a symptom and a sign. And a symptom is something that a patient experiences, and then communicates to you. A sign is something that you can observe objectively. So a symptom could be, a symptom would be pain. You can't observe pain as a vital sign. A symptom could be vomiting. They can tell you about it, but you can also watch somebody throw up. So I think it's important to keep that in mind moving forward as we're trying to design measures to assess symptoms in this patient population. Another respondent made a really good point that I think we need to make sure that we keep in mind. They said, unfortunately, with this scale, there is no way for a parent to indicate if they are unsure of the appropriate response. The respondents tend to drop out and not complete the survey and feel frustrated by asking to participate when they can't fully share their experience. And this has a snowball effect where people are less able to participate, and then that marginalizes the population that we're trying to study. And then that makes any research that we do or clinical decision that's made less inclusive of a population that already is extremely vulnerable. I thought this was very well put. This person said, on the majority of the questions, I just had to take a wild guess. I feel like my responses were garbage. And in the results, there were a ton of missing values. And when we're computing the score for these kind of things, there's ways to deal with missing values. But in general, the more missing values you have, the less useful the data are. And then the other point this person made is it's probably true even more so for individuals that also have sensory reactivity abnormalities and feel things differently than most people. And that's something that's often not appreciated, especially for developmental disorders that include autism, is that there's almost always some degree of sensory processing difficulty, either not sensing pain, not responding to pain, not being aware of pain, having a higher pain threshold, are all things that can get in the way of accurately reporting symptoms and accurately giving a diagnosis, and those kind of things need to be accounted for. And this one broke my heart. So this person said, the questions were so out of reach for me. It makes me feel bad because most parents of neurotypical kids probably can answer these questions. And that is a daily feeling for a parent of a neuroatypical child, is that you either have friends or family or siblings that you are constantly comparing them to, and it's a very difficult thing to shake that your child is being marginalized. And I think this happens across the lifespan. And this is somewhere where we can stop that, where we can say this is a population that not just of patients, but of parents, where we need to be addressing their needs as well. And then the other issue, and I alluded to this with Cecilia, that a lot of these surveys, they have a time, and sometimes it's too long, and sometimes it's too short, and that may be different for those with neurodevelopmental disorders, because something that happens once a month for a neurotypical person may not cause too much functional impairment. But for somebody that already has 9 other medical problems and is taking 10 medicines, just once a month of not pooping at all can be dramatic. And so we have to modify the way that we assess these things to take that into account as well. So my takeaways from the qualitative portion, the first, I think, and this is really driven home by the family panel earlier, is that it's essential to involve families in each stage of developing measures, especially for research. That has become the standard, and most high quality clinical research now has at least one phase where you have the input from families, from those that have a disease, from industry, from a broad array of stakeholders. So if we're going to develop better measures, we have to involve families not just at the beginning or at the end, but throughout the process. The other is that, in the clinic or in research, measures need to be brief, easy, and relevant. Many families talked about how difficult it was to complete these actually pretty long, measures, and those that have kids with special needs are more susceptible to this. They're less likely to participate in research. They have less time to devote to it, and we have to take that into account. We also have, as multiple parents mentioned in these qualitative comments, that the individual that you're assessing is often nonverbal, and often at the very least has some degree of communication impairment. That has to be taken into account. And then along those same lines, many people have sensory processing dysfunction of some kind. And those are things that are not well understood. We have names for things like sensory processing disorder. But my experience is, at least, is that this has a dramatic effect on things like constipation, the ability to sense that you're going to have a bowel movement and respond to it by squeezing a certain set of muscles, and this is something that's not typical of most children, and we have to take that into account whenever we're deciding how to treat these problems. A large number of kids have medical complexity, or they're on other medicines. Like Stephanie earlier was talking about how one doctor recommended stopping a medicine that was working really well because there was an effect on a different body system. That happens all the time in kids with neurodevelopmental disorders. And and I also, and this is something that I feel very strongly about, we can't treat this population of patients like they're just a flavor of typical patients. And in pediatrics, the thing we tell the medical students all the time is children aren't little adults. And it isn't because, we use the same medicines and we dose it by age, but there are so many complex things that you have to do differently to take care of a child than you do to take care of an 80-year-old, that you can't just take every lesson you learn from one and use it on the other. And in the same token, I would say that neuroatypical individuals are not just partial human beings. They aren't people minus the ability to do things. It is so much more complex than that, not to mention dehumanizing. And I think we in medicine and in research need to start looking at this population as being unique and work more to be inclusive. Okay, so now I'm going to show you a bunch of graphs. So if you don't like graphs, this is the part where you can take a bathroom break. We asked age, and we found that the majority of respondents were parents of children under 18, but we had about a quarter or so were adults. And in a lot of problems, this might be more relevant, but I think a lot of our kids, just them turning 18 doesn't change much. They still require the care of their parents. Most patients were non-Hispanic or Latino. Most patients were white. And this is, unfortunately, as in most medical problems, there is more participation in research and more access to subspecialty care in those with higher socioeconomic status, which is absolutely not acceptable. And so that I don't get into this too much, and it hasn't been a focus, but I do think one thing we need to make sure that we're continuing is to be inclusive of everyone when we're trying to solve these problems. As people of color and people with lower socioeconomic status are more likely to be adversely affected by these problems. There's slightly more girls than boys. And then, this was just kind of a fun question, was, what's your eye color? And brown won, but it was very close to blue. And this was my favorite question. This was asking hair color. And as you can see, my people are not as well represented as we would like. and this is kind of why I'm biased, is that, we have a house full of red-haired kids. Um, and but that roughly matches what you would expect in the general population. So we also approached multiple different organizations, and many of these are part of the group of organizations that we've asked to participate in this. Dr. Holliday is in charge of something called Agenda, which is this alliance for organizations that have a genetic disorder that causes developmental problems or autism. And as you can see, the important thing here is that the other category had many broad different types of genetic diagnoses. So we're looking at this extremely heterogeneous population. But as I noted before, there's probably more that we have in common than is different. And we need to find the commonalities and work together to come up with treatments that and diagnoses and assessment methods that can be used across this whole population. This should surprise no one, but constipation was the most common symptom. All of the rest of the symptoms were roughly the same, but constipation seemed to really have the biggest impact on people's lives. And you'll see that among the speakers that we have is that constipation will probably be talked about more than anything else. So now let's look at the results from the actual numerical results from the survey. So the first one was the PEDS-QL survey. So this is something that is scaled between 0 and 100. And 100 is like, my life is perfect. I don't have a care in the world, and I'm in perfect health. And then 0 is I'm in utter misery. And the average person has a quality of life score on this metric of about 88. So I think it's very telling that, and this is across a whole bunch of different symptoms. So there's 10 or so different symptoms that this looks at, and this is the composite score for all of them. And each of the PEDS-QL surveys is for a specific age group where the questions are age appropriate. And as you can see, in the 2 to 4 age group, it's kind of roughly all over the place. But there's a big chunk of people that are well below that normal healthy person of 88. And then as you get older, that difference persists. You have this kind of curve in this histogram that is way shifted below what we would expect. And again, this is not for overall well-being. This is just quality of life related to GI symptoms. And then as you get older, not really any changes. In the 8 to 12 group, again, it's this roughly bell-shaped curve, but the middle of it is well to the left of higher quality of life. And then in the 13 to 18 age group, same thing. This is shifted actually a little bit to the left, so things got a little bit worse in the 13 to 18 group. And then the only one that was really different statistically was in the adult population. So we had an even more dramatic shift to the left. And so there may be several reasons for that, but that was the only big finding that we had from this survey, was that as you get older, it seems to get worse. And the median across all age groups was 62, which was 25% less quality of life than for healthy children related to GI problems. I will note, though, that this type of survey methodology does bias us towards worse results. So we didn't assess a whole population of those with neurodevelopmental disorders and then ask all of them GI questions. We sent it out, and so that people that had GI problems were more likely to answer. So this is not how we would determine prevalence in a population, and this wouldn't be valid to actually compare this to a normal population. But this is sort of where you start. The only statistically significant difference that we showed was that in those that were over the age of 18, they had a median of 57 versus 65 for those that were younger, which is, I mean, that's about 10% less life quality just related to GI problems. That's still significant. I have several hypotheses for why this might be. I think there's a progressive nature to many disorders. In Phelan-McDermid syndrome, for instance, which Cecilia has, there's often a period of regression that occurs in young childhood or adolescence. There also may be improved communication. Kids might get better at telling you that their stomach hurts, or showing you or telling you where it hurts, or something that might be ascribed to something else, to seizures or something neurological. Once they can tell you, they might say, "I have to poop." There may be more experienced caregivers. They may have a better idea of what their child is actually trying to communicate with them. But these are all just guesses, and these are things that I think we should study moving forward. So then PROMIS gave us some similar but slightly different results. So the PROMIS result gives you something called a T-score. And the PROMIS scale is developed through this effort through the NIH to look at a lot of different problems, and this is the one specifically for GI problems. And the way it works is that a T-score of 50 is where your average healthy person lands, and then so anything that goes to the right of that is more impact that your symptom or your disorder has on you. So somebody that has a T-score of 100, which I think actually might be mathematically impossible, is going to be dramatically more affected by 50. And just a shift of 10 is one standard deviation. And so you can see that the global scale, and this doesn't just include GI stuff, this is an overall well-being scale, that it was almost 2 standard deviations. The median is almost 2 standard deviations worse than the general population. And then whenever we focus on on individual symptoms, so the PROMIS scale actually looks at, rather than age groups, it looks at individual symptoms. You can see that abdominal pain, again, this is normal. Right here in the middle is where I hate to use the word normal. This is a typical healthy person. It's shifted way to the right. Constipation, as you would expect, shifted by about 1 standard deviation. Diarrhea, we had, and the reason that we have some kind of all over the placeness for some of these bars is that we had some incomplete data. So all 700 plus people didn't answer all of these. So for the ones that are a little more scattered, those tended to be ones that had less respondents. The diarrhea and swallowing curves, diarrhea was probably the least impactful, and swallowing, again, not surprising in a population of kids with hypotonia that they would have swallowing dysfunction. And you guys do have to forgive me when I say kids. I'm a pediatrician at heart. When I say kids, I mean people, but they're still somebody's kid. So and then for nausea and vomiting, sort of similar, and then for GERD, sort of similar. So the takeaway here is that every single one of these has a big shift towards more suffering, and that it was most dramatic and only significant statistically, among these different things between abdominal pain and constipation. So yeah, and as I mentioned, that healthy control is 50, and then any deviation over to the right meant more impact. And then as a side note, I I flipped the scores for the general scale because it's often reported in reverse. But just for the purposes of making it clear what I'm reporting, everything to the right is more suffering. And then when we compared the different symptoms, constipation and abdominal pain were more prominent in this population. But I do want to mention that there's no standardization for neurodevelopmental disorders and autism for this measure. This is something that's done in a general population. And then, but there is some hope, Calliope will talk more about this, later on. But there are people working on better scales that are specifically aimed at the NDD and ASD population. So Dr. Margulis, who's also one of our speakers, helped, along with some giants of the pediatric GI community, helped develop this scale, specifically looking at common GI symptoms in ASD. And what we need is more of these, and to validate them in larger populations, to validate them in specific genetic disorders. And this is I don't want to paint the picture as being bleak, because there's people that are really working hard on this problem. But I think there's a lot more that we need to do. So I want to close with, and I want to emphasize that this is my opinion. Although I do feel very strongly about it, and this sort of mixes my opinion as a parent, as a gastroenterologist, and as a clinical researcher. I think the first thing is that we need to modify diagnostic criteria, especially for functional disorders, so that they're inclusive of individuals with neurodevelopmental disorders. So for instance, that one criterion I showed you earlier, where it can't be explained by something else, it's not that easy. In your average typical child, they have one medical problem, and that's what you're trying to diagnose. But in someone that has a lot more medical complexity, it's a lot easier to say, oh, their cyclic vomiting or their irritable bowel syndrome or whatever may be due to their autism. And I think it's just more complex than that. And so I would propose that we develop diagnostic criteria that either are fully inclusive or even may need to be separate for patients that have these disorders. And then my hope as an offshoot of that is that we can develop an extensive toolbox of validated measures that are specifically can be used for patients with NDDs and autism. And as Heidi mentioned earlier, there's been some commitment from funding agencies like NIH to actually study these problems, but this has all been very recent. And in my opinion, at least, there needs to be a much bigger societal investment in solving these problems. Our children are very expensive. Our children are suffering. Our children represent huge amounts of lost work and family dysfunction. And the more we can invest at a societal level, I think that it will reap rewards well in excess of what we invest. One other thing I think is important is for us to, I'm sorry, two other things I think that are important. One is that we need to be better about sharing data. Right now, we're all in our silos studying things, and we need to work on coming together in a centralized way so that we're not all reinventing the wheel and we're not repeating things that don't need to be repeated. This helps us share resources as well. And there's actually a one of the working groups is focused on this idea of data sharing. And then another one is focused on measure development. And the third one is focused on the last point I want to make, which is that we need to enhance postgraduate medical education. In my opinion, most clinicians aren't nearly as good as they should be at dealing with patients that have neurodevelopmental disorders. They tend to lump them all into one group, and often there's a lot of dissatisfaction from families. At the very least, and I admit to doing this, at the very least, a doctor should look up the Wikipedia article on the rare disease that their patient has before they walk in the room. But really, the best thing to do is to use families as a resource, because they're always going to know more about their rare disorder than the doctor does. And this is, as an update, this is Cecilia now. She's 6. She's made a lot of progress. She's very good at telling us what she wants. She's not very good at accepting the answer of no. And then at this point, I would be glad to answer questions. And then after this, we have about a 10-minute break.
Thank you, Dr. Bennett. As you said, not surprising, but I think it speaks volumes that 717 families that don't get sleep and don't have time for a daily shower took the time to answer those 2 surveys. And I hope that all of our stakeholders were impacted by the stories that put me in tears. And I'm a parent of a child also with Phelan-McDermid syndrome and have been fighting this fight for 20 years. One of the questions we got was, will the results of the survey be posted on the candidgi.com website?
That's a really good question. Yes, we can absolutely do that. What we want to do is actually publish this so that it's peer reviewed in the literature. And I think making that publication available, plus also these slides and figures sort of detailing the results, I think we can absolutely do that.
Okay. Another question was, is it necessary to do research based on specific genetic diseases, or can it be done across all of these neurodevelopmental disorders?
That's an excellent question. So I think the answer is both. So I'll give you an example. So for Phelan-McDermid syndrome, there are some problems that are unique to the specific genes that are lost. So one of the genes that's in the region for Phelan-McDermid syndrome can affect how your liver works. And there's only a few genes across the whole genome that might cause the same thing. I wouldn't necessarily be able to use that particular gene to say that somebody, say, with trisomy 21 might have that same problem. So we have to identify those things that are unique for rare disorders, but then we also have to look at those things that are in common. So like one thing that's really common is hypotonia, and that affects the GI tract as well. Another thing that's common is sensory processing problems, so that people have a hard time communicating. Another thing that's common is seizures and the need for medications that affect the nerves, like anti-epileptic drugs. So we really need to look at the things that have a lot of commonality and work on ways to assess and treat problems with those common elements. But we can't lose sight of the fact that we're dealing with a lot of people with rare disorders, and there are unique features that need to be taken into account that might need to be, things may need to be modified for individual disease communities.
Excuse me. This is a related question. Clinical care guidelines are difficult for a lot of these diseases. The support groups don't have resources. A lot of their scientific advisory committees are shared amongst many neurodevelopmental disorders, and each one is doing a one-off. What is the likelihood, or what are your thoughts on more blanket clinical care guidelines for NDDs in general?
I think that is an essential eventual outcome from this entire concept, is we need to help clinicians have ready access to evidence-based guidelines. And we certainly need to build more evidence so we can have better guidelines. But I don't know where to look for something for a rare disorder, but I may not need to go look for what to do about that rare disorder. I may just need to understand, how do I treat constipation in children with autism? And there are a few efforts to do that, but I think we need to have a bigger, more sophisticated, more inclusive, larger effort to have guidelines that say, this is how you treat these common problems in patients who have special needs. And I think that's going to take people that have a lot of experience writing guidelines. It's going to take a lot of investment across a lot of stakeholders. But I would say that that's an absolutely essential, downstream result of this kind of coming together. So yes, the answer to the question is yes.
Okay, great. This next question got 3 upvotes. How can we get more appropriate GI medical care from doctors in our area? They just don't know what to do.
So I'll answer this question as a parent. If you don't have a good relationship with a doctor, or you aren't getting the answers that you need, do not be afraid to seek another doctor. I know that's easier said than done. A lot of people don't have the resources to, drive 2 states away. But there's a wide gulf in expertise among different specialists. Like I am not an easy parent to deal with my daughter's doctors. Although, admittedly, my daughter's gastroenterologist is Dr. Coffey, who's speaking later. So I have the ability to pick them. But so the first thing is don't settle for advice that you don't like or that isn't good. I mean, that's one of their jobs, is to convince you that what we're doing is the right thing. The second piece of advice would be you really want to engage with individual communities. There tend to be a lot of experience there about which doctors to seek out advice from. Personally, I talk to, I'd say 1 or 2 families a week where their kids have Phelan-McDermid syndrome, and I share my experience and try to direct them towards somebody locally who I think has the expertise that they need. I recognize that's a hard problem, but I think as every special needs parent recognizes, you have to keep fighting and advocating for your child.
As a parent, I will also throw in, and I live in an area that has a lot of great hospitals near DC, but the trick isn't finding GI doctors that treat PMS. The trick is finding GI specialists that work with all sorts of MDDs. And I think the same is true of epileptologists. The next question I can address, have you thought about reaching out to Spark, that has a large database of ASD and MDD patients with DNA results? We actually, this survey was shared with Simon Searchlight did share the survey out with everybody, and they're one of our collaborators. So I think we have time for just one more. Can we better differentiate between motility issues and malabsorption or food intolerance issues? Is there a value in this and relevance to track and report in GI field for those with NDD?
Yeah, I think we need more infrastructure for motility evaluations. One of the recommendations that we're going to make for the Phelan-McDermid syndrome GI guidelines is early access to a specialist, and then we really want to get people in to see a motility specialist if it's appropriate. But it's not easy to find people that do this. In fact, most of the people that I know that are really good at it are speaking. So we can't clone all these people. They're all amazing, but we can't clone them. We need more education in this. We need more clinicians that are familiar with it. And I think the main answer to the question is a combination of the 2 working groups that we have planned, which is data sharing and education. We need more clinicians that can do this, and we need more structures in place that let us share clinical data and clinical research data so that everybody isn't operating on their own in a silo.
Okay, great. My apologies if I did not get to your question, but please keep the questions going. We are tracking all of these questions, and we will be reviewing them after the conference.